going to tell you a story about diabetes. No, this isn't the time where you get to scroll through your phone or take a little nap. I'm actually going to tell you about this guy. Do I have your attention? Yes, that's Nick Jonas. What do we know about Nick Jonas? Well, we know he's a talented musician. We know he's 1/3 of the Jonas Brothers. And we know Nick has diabetes. And Nick Jonas uses a continuous glucose monitor known as a CGM to help him manage his glucose. Nick isn't alone. Over the last 2 decades, individuals have chosen CGM to help them manage their condition. CGM has significantly improved diabetes outcomes and reduced diabetes burden. It's made their lives easier. Despite these amazing technological advances on the outpatient side, on the inpatient side, we've been doing things the exact same way for 4 decades. Outpatient diabetes looks something like this, while on the inpatient side, we've been in a slightly less sexy time warp. Yep, that's Wilford Brimley. What do we know about Wilford Brimley? Well, we know he was an actor on the Waltons. We know he really liked Quaker oatmeal. We know he had diabetes. And we know he used a meter to help him control his glucose. And yes, we still use your grandfather's glucose meter in the hospital. But this divide between outpatient and inpatient technologies, it's not just about keeping up with the Joneses, or the Jonases in this case. Sorry, I couldn't help myself. No, it has real patient consequences. You see, glucose meters didn't work well in the outpatient setting, and they work even worse in the hospital. Let me show you how we use glucose meters in the hospital. This is Stacy. Stacy has type 2 diabetes, but she's hospitalized for pneumonia. She's actually doing really well, and her medical team says she's probably going to go home in the next couple days. Stacy uses a CGM at home. In fact, she hasn't used a meter in years. She hated them. They hurt her fingers, and she could never get her glucose exactly when she needed to. So she was kind of annoyed when she gets admitted to the hospital and she has to use a meter instead of a CGM. On this particular day, the patient care assistant, the nurse's aide, comes in and checks Stacy's lunch glucose at 10:30. It's 322, which is really high for Stacy. But that's because she just had breakfast an hour before and she'd received her insulin for that breakfast late. At 12:30, Stacy's lunch gets delivered to the room. The nurse comes in to check on her and give her insulin. Stacy's pretty sleepy, but she said she's hungry and she's definitely going to eat her lunch. The nurse follows standard insulin dosing guidelines and draws up the insulin to lower or correct Stacy's glucose of 322. Except that isn't Stacy's glucose anymore. Not when she receives that insulin. You see, glucose is a really dynamic biomarker. It changes really, really quickly, and the insulin that Stacy had received at breakfast is still in her body, lowering her glucose. Stacy's glucose isn't 322, it's 52. And Stacy wasn't sleepy, she was having a hypoglycemic or low blood sugar event. Stacy never ate her lunch. And as her glucose continued to drop, she drifted into unresponsiveness. But nobody knew it for another 48 minutes, and it took another 20 minutes to get a glucose check. And by then, the meter just read low. Stacy's glucose was less than 10. Stacy didn't go home in the next 2 days. Instead, she spent the next 2 weeks struggling and recovering in the ICU. This is a true story, and the processes and issues that I'm describing here, these are the norm in the hospital, not the exception. Data shows that on average, there's a 90-minute gap between glucose checks and insulin delivery in the hospital. And the issue here isn't just that the glucose was checked at the wrong time, resulting in the wrong dose of insulin. It's that there was a failure to detect a hypoglycemic event for over an hour. CGM could have solved both these issues with real-time glucose monitoring and alarm capabilities. So why aren't we using CGM in the hospital? Well, it's because it's not accurate enough, or at least according to the FDA. But when we say accurate, what we really mean is accurate compared to what? A glucose meter? A meter may be more accurate at a moment in time, but as each minute passes, that value becomes less and less accurate. What we really should be focusing on are patient outcomes and clinical utility, not percentage points of accuracy. At Ohio State, We've been using CGM since the COVID-19 pandemic. We started using it as part of the emergency provisional allowances to help protect nurses from the virus. That clinical work led to a large clinical trial in our medical intensive care unit. We trained nurses how to use these systems. We placed sensors on ICU patients. We created new workflows, and we studied the results. In all, we've used CGM on over 250 critically ill patients, and the results have been remarkable. Improved glycemic control, decreased dangerous lows, improved recognition of glucose trends, and nurses that say, "I never want to go back." This year, Ohio State passed a clinical guideline making CGM the standard of care in all of our ICUs. We're not waiting for another regulatory cycle, for the government to reopen, for the FDA to have another meeting. We're not waiting for anybody else to tell us that hospital patients deserve the same technologies that everybody else already has. We're not waiting because every moment that we do, someone like Stacy might pay the price. We're not waiting because nurses are ready, patients are ready, and the technology is ready now. It's time hospitals got on board. It is time that we brought the future of diabetes into the hospital. Thank you.